Hello guys, my name is Nadine Akari and I'm doing orthopedic surgery for ISM. The first thing I thought of when I was a fetus
Keep going, go. Just go.
when I was a fetus oh god, I can't do this, okay.
Keep going.
Whew, okay. So So when I was a fetus, I don't remember what I said before. Okay, I'm starting over. That's not how I started it last time. Okay. Alright, my name is Nadine and I am doing orthopedic surgery for ISM. And my passion for medicine just started when I was a fetus, and you guys might be wondering what that means. And that means my parents already decided what they wanted me to do, and that was to be either in law or in medicine. And that was a very hard choice making when I was little because I didn't know what either of them was. All I really know, whenever I go to the doctor's office and I was like, ooh, I want to be them. And so at 6 I chose to do medicine because my brother actually chose to do law, so I couldn't have another choice. He's older than me. So then we moved on, and I didn't know what I was getting myself into because now I realized how many years of schooling it takes and how hard it is to get into medical school and how smart you have to be able to get through medical school. But then I was introduced into ISM, and I was fortunate enough to be introduced to it because I didn't want to go into college not choosing a degree plan that I did not want to pursue and waste my time doing that and just have to start over and do a different degree and waste money and all that stuff. So ISM was there to help me choose what I wanted to do and if I actually liked it. And the quote that I found that actually helped me out this whole year has been, "No one can make you feel inferior without your consent," by Rosa Parks. And that was very dear to my heart because it makes sense for me to only be able to choose what I want to do and not my parents or anybody else. My mission statement was to enhance and harness a deeper understanding of a career where individuals are fortunate enough to have the ability to save human lives. And that was because I didn't really know what I wanted to do. I didn't know what medical field I wanted to be in. I just knew I wanted to help and save lives, and that mission statement really put everything together for me. And then I was confused in what part of the medical field I had to go into because I couldn't just say medical field. I had to say surgeon or doctor, or I had to say psychologist or something completely different. I really didn't know, so I was stuck. And then I realized I want to do surgery because I'm very hands-on and I'm a visual learner and I'm very active and I don't like being just in one place. I like standing, I like being involved, and I like being part of the solution, not the person who says what to do for the solution. So that's why I thought surgeon, not doctor. And I also watched Grey's Anatomy, so that was a very helpful part of my ideas. My research and interviews helped me decide what I wanted to do. In the beginning, because I didn't know what I wanted to do, I researched about all the stuff to get into medical school. And the first thing I saw was that medical schools were actually increasing in size and people were wanting to go to medical school, not the other way around, because everybody's been saying, oh, nobody wants to be a doctor anymore, it's not the right field to go into, it's not worth it. So I realized that people are becoming more inclined to go to medical school and actually finishing. And this is what this shows. And then I realized, what do I have to do to get into medical school? I have to take the MCAT. And then I found a research article talking about the MCAT, and the MCAT was changing, and of course it's changing whenever I have to go into medical school. And it's going to be very, very long, 6.5 hours long, and it's going to have psychological, social, biological, critical analysis, and reasoning skills, which is good because it's not always going to be science. It's going to be more about what you want to do in your life and not just science, chemistry, and biology. Because you also need people skills. So then I started interviewing people, and after having called over 40 people, I got able to meet 6 of them. And Dr. Nace was my first one. He introduced me to the different view of surgery. He did a lot of research, and he told me that the money isn't as good as it used to be, and he didn't make as much as he wanted, but it also was very helpful because he told me that surgeons cannot help but get affected by their patients, which means whenever you're a surgeon and somebody dies on you, then you have to be able to know how to cope with it. And that's something I wanted to research, and I did. And it said operating rooms have highest risk for complications, and surgeons have really high attachment to their patients, and if they do get that attachment, then they don't really want to be a surgeon anymore, or that they're more inclined to continue surgery. So it's either one way or the other. So then I figured out, so doctors are leaving, what's happening to the patients? And I did some more research, and I found out that the world was aging, and it's not becoming more births, it's becoming more deaths. And I was wondering if doctors are even needed anymore, because nurses are more needed now. And so here is a little map about what's happening in the world and the diseases that are happening. And over 35% are happening in Africa and Asia. And that's something where I want to do international studies in like being a doctor. And I thought that was really interesting that it's needed. And then here is showing how in Nigeria there's a less than 5 to 10,000 people ratio for doctors, and that made me really sad, and it made me more encouraged to become a doctor because I could be able to help people in those countries. By 2030, 22% of the world will be old, and that's why more deaths would occur, which means I am needed as a doctor. And that's what Dr. Benet told me, and he said that our generation is going to be the one helping out the most because we're so used to everything that's going around us, technology, and even just how society is changing, because people in older generations don't really like how society is right now. And he taught me the technology is a huge part of the future, and to never give up, even if everyone's telling you you'll fail, because he moved from France to Los Angeles and then back to Texas, and he's been through a lot, but he's where he wants to be. And then I met Dr. Haslam, and he works for the school in a way that he's the doctor for our student athletes, and he comes in and checks up on them, and he was very good inspiration because he has a family and he loves his job and he has a lot of passion for what he does, but he also takes a lot of time and makes sure that he balances his life out, which is something I want to see in a doctor, not somebody who's divorced and doesn't really like his job. And so that's why I picked him as my mentor, and he told me that he was specialized in sports medicine, and he's given me many great opportunities and advice on my final product. And I did some research on him, and there was all like comments about how great of a doctor he is, and it's really creepy, but I don't know, it was really interesting. I just wanted to see if everybody else felt the same way. And then I started talking to him about my final product, and then we thought about concussions because I was really into neuro, but then that didn't work out because there was a lot of complications, and it would have taken too much time and not enough privacy for the people who would be answering the surveys. So I turned over to OR turnover time, which is finding a more efficient and cost-efficient way to turn over from OR rooms. And the definition of a turnover time is the time from where the surgeon makes the last stitch on a patient to the time where a surgeon makes the first incision on a patient. So that's the whole time in between. And why is that important to me is because surgeons have complained about it for a lot of years, and no hospitals care enough to fix it, and it's a major issue in any medical field. And it's like, what if I ever bring it up and anywhere I am with Dr. Haslam, they're like, oh wow, that's like so interesting that somebody your age would even be wanting to do this. It's a huge issue in our world today, but nobody really realizes it. And so the questions I had been asked for my final product is, how many different surgeries will this intake? And so far it's been 2 to 3, but the same surgeries. And does turnover time differentiate between surgery? And I said yes, greatly, depending on the structure of each surgery. And how will the final product be presented is by a poster, a huge scientific poster. And how many hospitals are you using? I was going to use 2, but then we didn't work out that well, so I just used Centennial Medical Center. And how have you began the process for this product? I started watching surgeries, I started collecting data, and I started researching more about just the actual turnover time, not everything vague. It was more specific. So then my process for my final product included me going to the OR room for the first time, and here's a picture of me. I was very nervous, I was very scared, because I didn't know if I would like it or not, and I was hungry, because it was 7 o'clock in the morning. I was thirsty, because I didn't have any water, because I was late, and I was excited. So, my selfie. And then here's Dr. Haltham. It was early in the morning, and he was very ready to do everything, and he had his things on his feet, and it was cool watching him do that, and he looked like a alien to me whenever I saw him do that for the first time. And for that, it helps make inspection not go into the patient. And so the next few pictures are not going to be very pretty, but I saw a knee replacement for the first time, and this is a tibial joint service with severe arthritis, and you can see that it's supposed to be very white, but it's not. It's very nasty and not very white. And then I was able to play with the cement that they were using to put in the knee replacement, and they put cement in between the metal so it moves around like cartilage. I thought that was really cool that he was letting me touch it, and it would, if I had to hold it onto it until it gets hot, and whenever it gets hot, I told him so he would know that in the body it's hot too. So then over there is scrap techs, which I saw, and I was trying to see what they do, what they have to do for college, and see different aspects of the medical field. And so here's the test trial they had, which you can see by the green right there. And then the real deal was completely white and shiny, and it was really pretty. And her leg was really, really big, but her bones were really, really small, which makes not a lot of sense. But she was fine whenever she got out. They finished it in under 2 hours, I think. So it was but I was standing the whole time, and I was really tired from standing the whole time. So I don't know how Dr. Haslam does it every day. Whoa. Okay. So then I saw rotator cuff removal, and this is the OR room, and it was very dark because he was going through a hole, and in that hole there was water coming out because they were putting water in through her liquid and through her mouth, and it was coming out because of the hole, and it was really, really cool because it was like spilling everywhere, and he was very wet, and then his PA was very wet. And then this is the hole that he was going through, and there was a camera that he takes pictures of each time, and you can see like the cartilage being removed and making it better for the rotator cuff. And then after my first visit, I was really confused on what I was supposed to do next, and watching surgeries wasn't really what I was supposed to be doing, and what was happening in between surgeries is what the process was. So I asked Dr. Haslam, and I was like, what am I supposed to be doing right now? And I was really confused, and he told me to just figure out the process of a surgery and what happens before, what happens after surgery. And then I figured out the process. So I was able to visit with the nurses, and I got to see what they did before the surgeon and all of them see. And they took the blood pressure, and they measure the EKG, and they have like this cool thing. They say, like they have different colors of the thing that's put on their chest. So it's like fire, it goes with white, and then I don't know, it was really, I would not be able to memorize it, but it was cool that they memorized it. And then here's a bunch of stuff that they use. And they wanted me to do it for them because I saw them do it like 4 times, and I was like, no. I touched them down here, and I was like, no, I didn't do that. But I put somebody's socks on, which was cool. And this is a nurse that was interviewing, I guess, the patient. And then here's Dr. Haslam. Whenever he sees his patient for the first time, he signs them, and which is really different than any other surgeon because he's had people tell him before that they have gotten the wrong leg done, and it's just something that he's never been able to even think about. So he signs. He asks the patient, what one am I doing today? And then they tell him, and he checks on his chart to make sure that it's the right one that they're saying, and then he signs it. And whenever he goes in the surgery room, he looks for his signature. I put those yellow socks on, by the way. And then this is him writing down all the information that he sees. And this is the anesthesiologist rolling her in because he has to stay with her the whole time, right after he gives her the doses and right after she comes out of the surgery room. And this is the PA getting her prepped up for Dr. Haslam to get ready and to do her knee scope, I think it was for her. And this is him doing the knee scope. And then if you can tell from here that he has this wrapped around him, the linen of the bed, and then whenever he switches off to the PA at the end, when they're doing the stitches, he gives it to the PA. You can see they switched right there. It was really interesting. And then after they finish the last stitch, Dr. Haslam goes to the patient's family, and then he tells them the pictures, and the pictures I was telling you guys about before. He hands them. He draws pictures for them, to making sure that they understand what happened and that everything went well or everything went bad. And it was really interesting. And then he goes to his desk and he types up what happened, the report of what he did, but he found a new way to just copy and paste what he does each time, so it doesn't take him as long as every other surgeon, which was really interesting. And then while they're all doing that, the nurse is cleaning the surgery room, the OR room, and she's cleaning. She's by herself, doing this all by herself. That's probably why it takes so long. And then Dr. Haslam goes to his board and finds out what he has to do next. And this is a very small OR list, but I've seen really, really messy ones before when they didn't know what was happening in what room. So then after I did that, I was thinking, why was there only one person doing the turnover? Why wasn't there more people doing it? It would have been faster, but more efficient. And then I started thinking what I have to do to get the research done. I realized I have to get data for the turnover. I have to assess the employees and what they think about turnover time. I have to figure out how the information will be presented and how I will present the information. So then my final product is here, and I was first starting with research, and I really didn't know what to research, so I asked Dr. Haslam. He was telling me more about what I needed to learn. He sent me some links, and I found out this figure of what to do, and surgeon and anesthesiologist and nursing, what they do while everybody else is doing stuff. And it was really interesting for me to see that they all come together, they all happen at the same time. It's not just one thing at a time. This is a normal way people do it. And here, the one skill advice that I saw is that activities need to be performed sequentially, which means that they all have to happen at the same time. And the nursing completes room setup, and then the anesthesiologist visits patient in pre-op holding room. So they're all doing the same thing at the same time, and it was very hectic if they have to rely on each other the whole time, which is something that probably takes the longest from each one. And they have to pick instruments, supplies for the next case. And so here's the one after they made it better, and it made everybody do the same thing, but clean the equipment, help out each other, make it smaller, and don't make it as long. And the actual proven benefits of making a turnover time shorter is definitely the saving time of not taking so long, and it reduces 1,581 hours of every year, and it adds 543 cases, and it makes more rooms available for the patients, which makes patient satisfaction higher as well. And through the research of turnover times, I found out that involved staff, so that they all have to be involved together, and to develop turnover packets so that each person understands what they have to do in turnover, so not just one person does it, they all know what they have to do. And so then I started collecting my data, and then I have done all of this and figured out, you can tell in knee scope, and how long it takes, and ACL versus ACL, 1 hour and 58 minutes, because the instruments were lost, and they only had one pair of instruments, so they had to wait for it to be cleaned, and that's why it took so long for this one. And then it was 69 minutes up here because there was the shoulder scope between shoulder scope right here. It was they had to change the whole instruments, and there wasn't enough people cleaning the room, so it took longer. And you can just tell, but if it was the same surgery, it goes much smoother if it was completely different. And so I made the same figures that we saw before in the articles that I made the same figures for the steps that I saw when they were doing the turnover time. And here is what I made for the figure 1, what happens before surgery, what happens after surgery. And everybody kept saying the patient leaving the room takes the longest, which is understandable, but you can't really help that. And then I started assessing the employees, and I followed Caroline Costco, the one picture during the OR turnover time, and the other pictures And she said everyone tries to help out when they can, but she's usually the only one doing the turnover when everybody else is busy. So they all rely on her. And she told me that somebody will be telling her to do this, but somebody will be telling her to do that, and it just takes longer because there's not more than one of her. And while I was trying to find Caroline Costco, I found Sandy Beaver, and then she's the leader in the surgery office. And she told me that one thing that would make it turnover time better is if we had a housekeeper. Everybody has to do their own turnover. You can definitely do a project over this, and she was very inclined to tell me that it was very knowledgeable for me to be able to do something like this and be interested in something like this. And so how I was going to present it, it was the major problem throughout this, and I figured out that I could present it by having a scientific poster that Dr. Haslam has used before in his older topics, and he said that he would be able to let me use the layout, and then I just wrote everything from his layout online. But what were the corrections I had to make for the turnover to be even more efficient? And I said there had to be more people, the schedule similar structured surgeries in the same day, and by similar structures I mean that when a patient is sitting like this for one surgery and the next surgery they're sitting like this, it makes the turnover time way longer than if they were both sitting laying down, so that's the structure. So they don't technically have to be the same surgeries, they have to be alike in the structure. And all equipment should be cleaned and ready for each surgery beforehand, like the day before. They should be set up for each surgery that's happening the next day because they know what's happening the next day. More prepared, and the faster it goes. And why it hasn't been like this before is definitely customer satisfaction. And one of the major problems is in Texas, or in this city alone, is there's a lot of surgeons around, and the surgeon has to keep their patient, so if they say, no, I can't do it that day, then the patient will go find somebody else who can do it that day. And so they can't have really one day for one surgery, so that it's very difficult for them to have those kind of rules. And I was telling Dr. Haslam, he said, what I've been using since you started this project is I'll give them 2 options, and one option would be this day, and the other option would be this day, and they would feel like they have an option of what they're doing, and it would be their choice what day they had the surgery, but it would be really his choice because on those days he's doing those surgeries. So it was really like twisted back. And then at the hospital, there's not supply enough people to do the job, so they don't really care, they don't really see a benefit of hiring more people, so that's a really big problem. And it caused a lot of chaos whenever I was waiting for Dr. Haslam, whenever he sends patients, and I'll be waiting outside the room and just watching the nurses like fight and be like, oh no, I'm going in this room, no, I'm going in this room, and no, I have to clean that room first, and I have to clean that room first, and it was like, well, let's all calm down, don't you already know what you're supposed to be doing? And like, no, I have to leave now, my time's already done, and no, you're not, and it was like all back and forth. And so then here's my actual final product, and this is a little blurry version, but it'll be a huge poster, and here's my introduction, just trying to get people to feel interested in my topic, and then the data table that I presented earlier, and the figures that I drew on that paper, but I put them on the actual Word document, and the results for each one. I put the interviews that I had with them, 2 quotes about them, and discussion of why and how that hasn't worked, and how it could work the next time, and what can be fixed. And this is the layout that he sent me whenever he did his first scientific poster. And so for each part, the introduction, I put the Lone Star headline and the Centennial headline on both sides because it has who has helped me throughout this, and Department of Surgery, Centennial Medical Center. I haven't really had this approved by Dr. Haslam yet, so it'll be fixed most likely to see what he thought would be best because he's been busy, but we'll see how it goes. And I think I might have to be able to change some stuff throughout it because I need to make the font a little bigger to make it more easy to understand. And I had to put a hypothesis, so I felt very elegant doing it. And so then I had the data table, and I talked about what those methods do and why it's important to have those and have the same structured turnover time. And then here are the figures that I had of the time elapsing, and then how they all do. The nurse is doing all of this while they're just doing these 2. The nurse is doing all of that while they're just doing all those 2. So that showed exactly what was happening and why it took so long. And then I had the interviews from these 2 people, from Sandy Beaver and Caroline Costco. And then up the results, I just told them what those said. In the discussion, I had a picture of the OR nurse, and I had a picture of Dr. Haslam, and I just talked about exactly what I said before, how it can be fixed, and why it has been working in the past. And then I found out that I had a problem with the product. The font size was really small, I could barely read, and it might be too much information. So I might have to be able to fix that to make it more likely to be read. And then I have to print it out and hope for the best and see how it looks like, if it actually will be a final product or not. And how I present it to the Centennial Medical Center, I will present it to Angie Jones, who is in charge of presenting information to the board. And I will have to call her and set up a meeting and dress up all fancy to go talk to her, and be very nerve-wracking, but it'll be interesting for her to see what I have to say and what she has to say. And when will that happen? I hope it happens before May 20th, but it might not, depending on her availability and whenever Dr. Haslam finishes my thing. And I just wanted to say, to thank Dr. Haslam for his patience in this time. And I know it takes a lot of time to be able to do this with me and be patient with me. Do you guys have any questions? Okay, thank you.